Thank you everyone for joining us. We'll give it just 1 minute. We'll let people filter in. If you want to just sit tight for 1 moment, we'll be right with you and get the program started. So thanks so much for joining us tonight. All right, well, thank you so much everyone for joining us tonight. My name is Jen Crawford. I am the Executive Director of Physicians for a National Health Program of Minnesota. On behalf of myself and the board members at PNHP Minnesota, Healthcare for All Minnesota, and Minnesota Nurses Association, we want to thank you for joining us for our second Thursday educational program. So we do this every second Thursday of the month at 6:30 p.m. You can join us on Zoom and we will discuss a featured topic. So tonight we will be talking about HMOs, PPOs, ACOs, EIEIOs. So all of the acronyms, how managed care hogged the spotlight of healthcare reform. Tonight our presenter will be Rose Roach, the Executive Director of M&A. So we thank her for joining us this evening. Just before we begin, a couple of notes. There are a couple of features at the bottom of your screen. Please feel free to use the chat function if you're having any technical difficulties. If you have any questions for our presenters or hosts, please feel free to put those in the Q&A tab. We will view Rose's presentation, and then after she's spoken, we will discuss questions that folks have submitted throughout the night. So please feel free to submit those at any time. And if you want to pull up our agenda, I can take people through that quickly. Here we go. So tonight, Ann Jones, registered nurse and vice chair of Healthcare for All Minnesota, will discuss our program. After that, Rose Roach will give her presentation, and then we will wrap up by discussing some current events and action alerts, ways to keep you involved in the movement and everything that's going on. So thank you so much again for joining us, and Ann will continue for us. Ann?
Thanks, Jen, and welcome everybody. Before I turn this over to Rose, who's going to talk about some higher level, give you some information about how the policymakers and lawmakers became persuaded that fee-for-service and overuse of healthcare were the root causes of rising healthcare costs in the U.S. all the way back in the 1970s, and how 50 years of incremental market-driven reforms have failed to fix it. I'd like to create some context and talk just briefly about how managed care feels to patients, their families, and physicians, other providers, and maybe their office staff, just to help you understand what has been tried and really has not worked over the last 50 years at the kind of experience of patients and providers level. And then I'll turn it over to Rose, who is the the Executive Director of the Minnesota Nurses Association and board member of Healthcare for All Minnesota. So in case nothing comes to mind when you hear the words managed care, I want to give you a little background information, like I said before Rose talks. So and remind us that instead of moving to a publicly funded and administered national healthcare financing system, like most developed countries did following World War II, actually, we in the US have tried one after the other cost containment strategies and tactics in hopes of containing or slowing the growth in the cost of healthcare. So this slide lists kind of the alphabet soup of cost containment strategies tried over the last 50 years. The preferred provider organizations, health maintenance organizations, diagnosis-related groups, integrated service providers, accountable care organizations, and on and on. These were all put into place based on three basic assumptions about health spending in the US with very little actual evidence to back them up. First, the belief that Americans overuse healthcare, so making it harder to get will just somehow reduce costs. Second, that fee for service is the culprit. Doctors and hospitals just order too many tests and procedures just to make money for themselves. So various capitation schemes or controls will cut costs. And third, that if people have skin in the game under so-called cost sharing plans, meaning you will be required to put some of the out-of-pocket costs in order to get health care in the form of copays, deductibles, coinsurance, that you will be a better shopper, that being treated as consumers of healthcare, well, that will bring costs down. So this and the concept of value-based purchasing or value over volume, all that sounds good, but really puts the burden on patients in a market where they don't have the information, the time, the freedom of choice, or the market power they need to fend for themselves in this very complex system, often when they are sick or in the middle of an emergency. So this last one not only puts up barriers to care when you and your family most need it, but allows the insurance industry to preserve profit margins by pushing increasing costs onto the beneficiary. And I'll remind us all that the Patient Protection and Affordable Care Act, far from being a government takeover of healthcare, left this market-based system in place, instituted some regulatory constraints for the commercial insurance industry, failed to address prices for services, and put even more taxpayer subsidies in place for purchasing insurance, drugs, diagnostics, hospitalization procedures, and so on. So looking at this list of cost containment strategies, you will see that cost containment in healthcare started out back in the 1960s with good intentions. Try to avoid duplication of expensive facilities. The health maintenance organization concept also had some good intentions. An HMO would take responsibility for a population of patients, provide preventive services, management of chronic, complex health conditions, a team of providers who know you across the lifespan. All good, right? Over time, as these tactics didn't really work because they never really controlled prices, a number of other tactics and strategies were added, including limiting hospital stays, pushing procedures from inpatient to outpatient settings, delays or outright denials of doctor's orders for your care, and applying the insurance company protocol in place of the advice of your provider. Denials of coverage for procedures and drugs, forcing physicians, providers, and their staff to spend inordinate amounts of time arguing with pharmacies and the insurance companies and so on. So many of these tactics were in hopes that you would give up or just pay out the extra cost. We're going to hear from Rose about why this has really not worked and why another approach is needed. And it is long past time to fix how we pay for healthcare in this country. So I'm going to turn it over to Rose Roach, Executive Director of the Minnesota Nurses Association. Thanks, Rose.
Thanks, Ann. Hey, everybody. Let me go ahead and switch it over. Oh, Ann, you've got to take your slide down, I think.
Yep.
And then I can go ahead. All right. Let me put mine up here. Always got to fool around with the technology here, you know. So good evening, everyone. Ann gave a really good introduction on what we're going to talk about here tonight. I'm actually going to go off of video during the time that I'm doing this because I want you to concentrate on the slides, and I can't see myself. It drives me nuts when I don't know what the heck I'm looking like when I'm trying to present. So anyways, let me do the introduction on this by saying simply that for half a century, the United States has been steeped in incremental and market-driven reforms of our healthcare system that, quite frankly, as Ann pointed out, just don't work. So why don't they work? Well, it's because we insist on treating healthcare like a commodity using a business model format. And we all know that these failed solutions continue to permeate the healthcare reform debate even today. The false claims of efficiency and effectiveness in these market-based solutions needs to be exposed. That's why I've titled the presentation, HMOs, PPOs, ACOs, EIEIOs, How Managed Care Hog the Spotlight of Healthcare Reform. Little bit of old McDonald's had a farm there for you. So understanding how we got to where we are is really critically important for us in the fight for a sane single payer healthcare system. I also want to note on the front end that a lot of this information is historical. It's needed so that we can clearly see why we are where we are and hopefully stop us from continuing to try the same failed strategies over and over again, expecting different results. A presentation disclaimer that I also want to make is that you're going to see a lot of words because this is a presentation of substance. It's not just me or the nurses or the doctors or other single payer advocates that are saying the managed care diagnosis and solution to our healthcare crisis is a failed strategy. It is in fact a fact. So with that, come on, why won't this change? I can't get it to, what happened? Hang on a minute, guys. I'm sorry. It doesn't want to change. There we go. All right, now we got it. So just to give an overview, I'm going to talk a little bit about managed care ideology's diagnosis of why we have a high cost of healthcare and its actual impact on cost containment. Is it working? Does it work? What's the real explanation for the high cost of healthcare in the United States, including some Minnesota-specific examples, and accountable care organizations, ACOs, and value-based payments, which are nothing more than managed care 2.0. Couple definitions for you. Privatization. We all sort of know what that is, right? It's just shifting the provision of services from government to private sector entrepreneurs. Capitation is a way to pay doctors, chains, and insurance companies a set of or uniform a fee per year per enrollee, which is per patient. FFS, that's just fee for service, paying doctors a fee after they render a service, as opposed to paying them via a salary or a capitated rate. HMOs, health maintenance organizations, ACOs, accountable care organizations, IHPs and IDSs are integrated health partnerships, integrated delivery systems, and then of course, CMS, the Centers for Medicare and Medicaid Services, which is the agency that runs Medicare and Medicaid for us on a federal level. So let's get into the first subject here. Since the 1970s, managed care ideologues have been trying to diagnose our high-cost healthcare system. But is it an accurate diagnosis that they've made, and has the prescribed treatment worked? Well, not so much. So here's how these ideologues of managed care, this is how they explain it. I want to give thanks to Dr. Anna Malinow of PNHP for this slide, because it does a really good job of explaining this. Many healthcare economists hold to the idea that excessive healthcare costs in the US are due to two things: physician greed and patients getting too much care. So in other words, the fee-for-service model that pays for volume. Their solution to it is to squeeze physicians and then to squeeze patients. To squeeze the physicians, they recommend shifting insurance risk to doctors and hospitals, holding doctors accountable for the cost of care, giving them capitated payments for a certain population of patients by creating things such as HMOs and ACOs and PCPs and MCOs and IDSs, and now the new one, DCEs, direct contracting entities. Then you squeeze the patient and you make them stop paying so much for healthcare. You increase deductibles, co-pays, co-insurance. You undersure them, make them choose between a whole pill or a half, 3 meals a day or 2. And this is how the US uses market forces to control prices. Let me take a minute to show you a demonstration, also from PNHP, of how the business model for healthcare on a national level works with our Medicare program, involving the Medicare Advantage plans, which is the privatization of our Medicare program. So the business model is really quite simple, although it does require hiring a bevy of very smart actuaries to make it all work. So first, you make sure that you insure the right population. This is also known as cherry picking, right? These are the healthy people. Those are the ones you want in your pool, because then you don't have to pay so much money because they don't use healthcare so much. Then you make sure you don't insure the wrong population. This is known as lemon dropping. So we don't want sick people. We don't want to take care of them. That's too costly. Then you go ahead and offer inexpensive premiums, and you offer lots of extra benefits like a dental benefit or a gym membership or something like that. Then you turn around and you upcode how sick that individual may or may not be in order to make a profit. Talk more about upcoding in a minute. And then you give some back to improve the product. You might lower the premium a little bit. You might have out-of-pocket caps that you can provide, or cheaper eyeglasses. And you market it to the right population, and you repeat. That's how it works when we are looking at business model of healthcare. So let me say a little bit about physician coding and risk scores. So what do we mean when I say they're upcoding? So this shows how the risk score gaming works, which is how Medicare Advantage has been drawing serious overpayments since its full implementation in 2006. Medicare Advantage does this by submitting diagnosis codes that create more CMS hierarchical condition categories for each patient. It's a little wonkish, I know, but it's important to understand because it's the basis for how the business model for healthcare puts profit over patients. So let's look at a 76-year-old female with obesity, type 2 diabetes, major depression, congestive heart failure, with a risk score of 1.03. CMS pays that plan that does not upcode. This is just what they would pay for this at $9,000. If, however, the Medicare Advantage plan does the upcoding, meaning same patient, all the same medical conditions, but they dig deeper to find more codes, and they get her risk scores increased so that her risk score is now at a 3.63. Holy cow, now CMS is going to pay them $32,000. The plan reaps obscene profits, some of which goes to marketing, some of which goes to improve benefits, driving up the number of new members involved, but most of which is going back into profits, all the while draining the Medicare trust fund, driving up Part B premiums, and diverting money from other social services and goods. For each 0.1% increase in risk score at current enrollment levels, there are $15 billion in overpayments, $13 billion from CMS and $2 billion from Part B beneficiaries, and the Medicare Advantage plan takes $3.5 billion in profits. Risk score gaming creates a major transfer of wealth from taxpayers and traditional Medicare recipients to Medicare Advantage plans, and this is how Medicare Advantage ends up working. The Medicare Gold Rush. Borrowing from a recent Health Affairs blog published in the fall of 2021 by Rick Gilfillan and Donald Berwick, they described the Medicare Gold Rush created by Wall Street speculators as they increased the valuation of a Medicare Advantage beneficiary's covered life for an average of about $7,000. To put this into context, Medicare typically pays $12,000 per year per individual. Wow. So what happened? Did seniors suddenly all get really sick? No, the system just got very sick. Four main business realities drive the interest in Medicare-related acquisitions. Expected doubling of Medicare spending from $800 billion to $1.6 trillion in 2028. The consistent overpayment by CMS to Medicare Advantage plans despite lack of clinical benefit. The distorted market dynamics that result from these CMS overpayments, and the direct contracting model to privatize part of the $1.6 trillion that is spent. Of these 53 direct contracting entities that are out there, most of them, believe it or not, are investor owned. About 25 are provider based and controlled, a mix of ACOs, some for-profit primary care, and specialty groups. The rest are investor owned. 22 are either publicly traded or publicly backed by private equity and venture capital firms. The 6 insurers operate in 19 states with 57% of the entire national fee-for-service population and can potentially cover up to 20 of the 30 million lives that are up for grabs. So when we say DCEs hand traditional Medicare to Wall Street, we're not kidding. Remember the 80s? Giving seniors a choice of health insurance plans, achieving the efficiencies of managed care in the private sector? Well, that didn't go so well. Again, this gets a little wonkish, but hang with me. Unless you own stock in one of these 5 commercial insurance companies, which in the last 11 years had an average stock price increase of 800%, and whose average market capitalization increased almost 500%, compare this to the entire S&P 500, where stock increased 280% and market capitalization increased by 245%. Just look at the difference there with these health insurers. All of this tells us what Wall Street already knows. Medicare Advantage and now these direct contracting entities is the place to be. We're literally selling off Medicare to Wall Street. Back to the managed care ideology that we overuse healthcare, and that's due to the way we pay for healthcare on a fee-for-service basis, which makes these greedy doctors prescribe more healthcare than we actually need. That's insulting, and it's absolutely not true. It has become some kind of odd groupthink. There's no evidence to support this claim, which I'll talk more about in a bit. Here in Minnesota, insurance companies were quick to jump on this theory of overuse and fee-for-service bandwagon, and they made sure that elected legislators knew it. Minnesota is a high-cost state because we're a high-price state. We spend more per capita than the national average, ranking 36th in a 2009 CMS study. Yet we have a low rate of emergency room visits and hospital admissions, while length of stay and readmissions are close to the national average, proving again it isn't about overuse of healthcare. And in 2016, we're deemed to be among the nation's highest in healthcare prices. So how do we keep pretending that price doesn't matter? Administrative costs are, of course, a component of price. Just look at the explosion of administrative costs between 1980 and 1991, a time when managed care is all the rage. Not only do we see a significant increase in healthcare costs themselves, but there was a 502% increase in administrative costs. And we can't ignore the impact that this ideology has had on bringing about massive mergers and consolidations within our system that are creating healthcare deserts and are having a significantly negative impact on both patient care and the workforce within our healthcare sector. In Minnesota, consolidation has played a major role in our average healthcare costs, moving us from the category of average cost to becoming a high-cost state. Consolidation and merger frenzy has been a direct result of managed care, and it is not bringing healthcare costs down. It is causing, however, as I said earlier, significant stress to our direct care providers. You hear about nurses and doctors burning out. First off, nurses and doctors reject that characterization. Being burnt out puts the burden on the doctor or nurse and implies a lack of character. What our care providers are experiencing is moral injury. Moral injury occurs when clinicians are repeatedly expected in the course of providing care to make choices that transgress their long-standing, deeply held commitment to healing. Moral injury is caused by something beyond the control of the doctor or nurse, not a personal failing that they can fix with self-care. Consolidation within the health insurance sector, the giants, have made it almost impossible to enter the healthcare marketplace. You can see by these quotes that consolidations and mergers within our system make clear the fallacy of the common claim by those that are opposed to single payer, that somehow we've been robbed of choice. I mean, look at that quote. It has become increasingly difficult to crack the Minnesota health plan market. There's now little chance of market entry by a small newcomer plan unless it's sponsored by one of the giants. But this isn't the only it isn't only health insurance companies that are caught in this mania of mergers and consolidations. Hospitals are also engaged in that, which again results in higher prices. We're down to basically 8 major hospital corporations here in Minnesota, as noted on the slide, from the far north to the far south and everywhere in between. And just today, hot off the press, I saw an article that mHealth is in conversation with Sanford Health to actually merge those two systems together. So you can see here that the quote from the Robert Wood Johnson Foundation, the Impact of Hospital Consolidation Report of 2012, hospital consolidation generally results in higher prices. When hospitals merge in already concentrated markets, the price increase can be dramatic, often exceeding 20%. And there you see the list of the current systems as they are today. And Essentia is in talks with merging with a Wisconsin company, Marshfield, as well. So who knows what this is going to look like even within the next year or two. This privatization scheme only adds to the workloads of our government agencies overseeing these programs, and as I noted earlier, to direct care providers themselves. All of this adds, does not subtract from costs when it comes right down to it. You can see here some quotes from some various reports around the impact on DHS, our Department of Human Services, what's happening to physicians themselves when they're having to deal, and we hear this from nurses all the time as well, that it's more about charting and codes than it is about providing actual health care to their patients. Turns out that the prescribed treatment for the inaccurate diagnosis that we overuse healthcare because we pay for it based on a fee-for-service model ended up doing nothing to contain costs and actually did the opposite, driving prices up through added administrative costs and through market consolidation. Again, just to point out that quote that's highlighted there, we find that higher levels of local managed care penetration are associated with substantial increases in consolidation in hospital and physician markets. And to add to that, the really truly saddest impact that has been the fact that HMOs have actually harmed the sickest patients. We only have to look at what's happening within Medicare to see how the industry cherry picks the healthiest and lemon drops the sickest. For elderly patients treated under Medicare, declines in physical health were more common in HMOs than in fee-for-service plans, 54% versus 28%. That's a Journal of American Medical Association, or I think that's what it is, right, JAMA, quote, and then the Medicare HMO revolving door, the healthy go in and the sick go out. This is what we are finding. And I want to note that if you go on a Medicare Advantage plan, and then you find out how they are not so much an advantage, they are far more Medicare disadvantage plans, and you get sick and you're suddenly not able to pay what you have to pay to get your health care. You have a much narrower network, and the next time open enrollment comes up, you want to jump onto a traditional Medicare, that's fine, you can do that, but please understand that now the gap insurance plan that you would most likely want to buy with traditional Medicare can underwrite you, meaning they can decide you have a pre-existing condition and not cover any costs related to the care of that condition. It's absolutely criminal. In the early 90s, a study was done in Minnesota that demonstrated how HMOs and managed care were not working when it comes to decreasing health disparities, but the study was never published. This quote from the Minneapolis Star-Tribune article about the study being shelved because the HMOs complained about it demonstrates the inequity that exists in our healthcare system that was not and is not being addressed by managed care. In reality, it's exacerbating disparities, particularly racial health disparities. We cannot effectively address health disparities and inequity until we change the financing of our system. And I think it is worthy, again, I don't normally read slides, but once in a while, I think things up there are worth taking a look at. Minnesota officials suppressed a study raising questions about HMO care for poor people, including a key finding that women on Medicaid get far fewer cancer detection tests than women who can afford to pay their own HMO charges. The study of HMO care found that women on Medicaid got only 36% as many mammograms as other women and 79% as many pap smears. The math itself doesn't even compute. This quote from a 2006 article in the Wall Street Journal makes that very point. States that run their Medicaid program without the private sector involved, unlike us, we've got the private sector involved in Medicaid, shows an average administrative cost of 4 to 6%, meaning 94 to 98% well, that's not the right number. It's more like, I think it's more like 92, goes to paying for medical care. Insert the private sector, also known as these HMOs, and now only 80 to 85% of those precious healthcare tax dollars are going to direct medical care. That's not a very cost-effective or efficient way to run a healthcare system. Here's the thing. In the 90s, it became clear after almost 2 decades of playing around with managed care that it didn't work. We get into the early 2000s and guess what? Still no conclusive evidence to support this notion. And that's what it was and still is, a notion that managed care somehow saves money. There's the quote from 95. There is little evidence, however, to suggest that managed care either increases or decreases the number of physician visits or the use of preventive health services or the use of inpatient hospital care. We still do not know conclusively to what extent traditional managed care actually saves money for employers. And despite several years of experience and a multitude of conferences devoted to disease management and health promotion, we still do not have a sufficient number of methodologically sound studies upon which to base decisions. That's 2006. So here we go again. Let's keep doing this, even though we've got nothing to base on the fact that it actually is working. And in 2013, a Commonwealth Fund summary of a systematic review notes that the researchers found no consistent evidence indicating that any particular system of care or insurance, whether fee-for-service or managed care, has been more effective than another in minimizing overuse. Managed care doesn't control costs. It doesn't improve quality, and it's no better than fee-for-service at reducing the enigma of its own diagnosis on what's driving costs, which they claim is overuse. In 2001, the former editor of the Journal of the American Medical Association proclaimed managed care is basically over. People hate it, and it's no longer controlling costs. Further asking a really pertinent question. If it's not saving money, then why should we have it? He astutely notes, however, that dismantling it will be messy. He's so right, as we see managed care 2.0 rear its ugly head not long after this article was actually published. So let's just veer off for just a couple minutes and talk about what really is driving healthcare costs and see whether or not the managed care diagnosis of overuse and fee-for-service is in fact a correct diagnosis. To quote both Princeton economics professor Uwe Reinhardt, it's the price is stupid, and Gerald F. Anderson in his article in Health Affairs in 2003, They said it a little less blunt. He said it a little less bluntly, but nonetheless, he said the United States spends more on healthcare than any of the other OECD countries spend without providing more services than the other countries do. This suggests that the difference in spending is mostly attributable to higher prices of goods and services. This same story is told by other researchers as well. Here's from the Lancet. In 2014, prices rather than volumes of health services, contribute the most to explaining the higher cost in US spending. And I want to provide just 2 examples of high prices, starting with hospital charges. An OECD study done in 2010 found US price level of hospital services to be 60% higher than the average of 12 other OECD countries in 2007. Unfortunately, I want to note that healthcare data is always 2 to 3 years old before it becomes available for review, so we're always playing catch up with this. In 2015, the International Federation of Health Plans published a comparative price report which demonstrates in hard numbers what that pricing looks like, as you can see here. Spain, $424, the US, $5,220. Getting even more specific, when we look at a couple of common procedures, knee replacement and angioplasty, we see the same trend as overall hospital charges. This plays out, as we all know, in the price of pharmaceutical drugs as well. Knee replacement in Spain, $6,687, $28,000 on average in the United States. Angioplasty, Australia, $11,000. In the United States, $31,620. Price matters. We can't forget this little culprit, right? Administrative costs, the enormous waste within our system due to the fragmentation and the complexity of the system itself creates excessive and unnecessary administrative costs at every level of engagement within our system. Just look at the difference in administrative costs when comparing our Medicare system and Canada's Medicare system that covers all Canadians, not just those 65 and older, against private insurance company administrative costs. And that 34% that we talk about doesn't include the cost of patient and employer pay. This is in terms of their time and the resources that they have to put in when dealing with our convoluted system. The managed care theory that healthcare costs in the United States are high due to overuse and a fee-for-service payment model was studied by Deborah Kornstein et al. In a study that was entitled Overuse of Healthcare Services in the United States, an Understudied Problem. It was published in the Archives of Internal Medicine in 2012. Interestingly, the editor of that same publication, Michael Katz, wrote a follow-up to the publication of the story that was entitled Overuse of Healthcare, Where Are the Data? Arch Intern Med from 2012, he said he was so struck by how little evidence Kornstein et al. Found that he felt compelled to comment on it. He said, what is most striking about this report is how hard their authors searched for data on overuse of healthcare and how little they actually found. They viewed 21 years of the medical literature and evaluated 114,831 publications, yet found only 172 articles that addressed overuse of healthcare. The question that Katz asked, where are the data, is a good question. After half a century of screwing around with HMOs, PPOs, and ACOs, all of which were promoted in the name of reducing overuse caused by fee-for-service, you'd think we'd have some solid evidence of an epidemic of overuse. Guess what? We don't. We still don't. And for the small pockets of overuse that do exist, we have no evidence that they're caused solely by fee-for-service payments. So the bottom line on the managed care diagnosis of overuse due to a payment system based on fee-for-service, it just doesn't hold up. As published in Health Affairs in 2001, in fact, a direct association between fee-for-service payment and overuse has never been established. That's directly out of that article at Health Affairs. Now, fee-for-service isn't perfect, but it's not the core culprit of high cost. We're paying the wrong fees for the wrong services. For example, we pay more for a knee replacement surgery because it's very lucrative for hospitals than we do for mental health services. And that way we do need to reevaluate fee for service, but not because it's the sole reason for high costs overall. It isn't, but because we need to bring parity to our care delivery system. But how on earth do we even do that when we have no consistent payment system? Underuse, by the way, is far more prevalent in our costly system than overuse is by a factor of 4 to 1. People choose not to access the system due to the number one barrier, which we all know is cost. You can see here in a couple of different studies where they have found that to be the case, that underuse is far more a problem in our system than overuse is. So now let's move into the last portion, which is the section on this idea that we're going to just continue figuring out how to tweak all of this. You know, as George Carlin used to say, I don't believe there's any problem in this country, no matter how tough it is, that Americans, when they roll up their sleeves, can't completely ignore. But what we appear to be ignoring is not so much the problem, but the obvious and the proven solution. ACOs. They're based on the same flaw theory as HMOs. There's an assumption that the problem is overuse. There's no evidence to support that assumption. It's based on an aspiration for achieving lower costs and improving quality. It's causing more mergers and consolidations. And again, it has failed in its aspiration to cut costs or to improve quality. Insurance companies saw real opportunities with these ACOs and quickly started setting up their own. Here's that aspiration getting tossed on its head as the healthcare market sharks start to smell blood, pun intended. Humana medical director, Dr. Tom James, said the insurer wants to show that health plans have a role with ACOs, adding that it's important that ACOs be seen as more than cost cutters. If not done right, it could give the whole movement a bad name, he said. We learned that with HMOs in the 1990s. And consolidation becomes centered in the rush to establish these HCOs. Quote, when Congress passed the healthcare law, ACA, it envisioned doctors and hospitals joining forces, coordinating care, and holding down cost. Now, 8 months into the new law, there is a growing frenzy of mergers involving hospitals, clinics, and doctors groups. And that it was published in 2010 in the New York Times article as health law spurs mergers, risks are seen. Interestingly, not even a CMS contractor could explain how an HMO, an ACO, see, they're interchangeable, we're supposed to reduce overuse, stating that it's a financial arrangement wherein provider organizations attempt to reduce expenditures below a set target while maintaining high quality metrics. That's a presentation, by the way, unto itself, in exchange for bearing risk for reducing expenditures. What a bunch of gobbledygook that is. It clearly doesn't tell us a thing about what on earth an ACO is, how it is supposed to reduce costs, and how it is actually supposed to improve care. None of CMS's ACO programs have actually saved any kind of substantial amount of money whatsoever. Now, MSSP, again, another acronym, it stands for Medicare Shared Savings Program. This is the largest of the 4 ACO programs that the Center for Medicare and Medicaid Services has conducted. This MSSP is a permanent program. It was created by the Affordable Care Act. All the other ACO programs that were implemented after 2010 were brainstorms of the Center for Medicare and Medicaid Innovation Center, also something that was created by the ACA. The MSSP is by far the largest of the ACO programs, making a quote about its trivial effects on quality particularly worth noting. It's also important to note that CMS does not take into account in figuring out savings how much is involved in the cost of setting up an ACO to begin with. When you do, any tiny savings that you see there, it quickly evaporates. So they're not actually saving money anyways. So how about improving quality? That's the other thing they're supposed to do. Well, again, not so much. Small improvement on a few quality measures, but no impact or a slight worsening on a number of others that were found. This is a Medicare Payment Advisory Commission report from last year, June of 2021. So very recent report showing that this stuff just is not working. And then we have value-based payments. Sounds so logical. Well, who doesn't want to make sure that we're paying for quality, right? The American Association of Family Physicians describes value-based payments as, and I'm going to quote, an aim is to promote enhanced population health management that should result in the improvement of health and or systemic cost containment or reduction. VBP uses alternative payment models or pay-for-performance arrangements to create a combination of incentives and disincentives intended to encourage better health care decision-making by tying compensation to certain performance measures. So, if the care provider can care for you for less than the capitated amount allotted, they share in the savings. If the care they provide exceeds the capitated amount, then they're penalized. Is using perverse incentives really a good way for us, do y'all think, to deliver healthcare? Healthcare doesn't work that way. It doesn't operate on a theory of supply and demand like consumer goods market does. Healthcare isn't a consumable good, and treating it as such is causing these high prices, and worse, it's costing patients lives. This is absurd and ridiculous to think that this is how we should incentivize paying for our healthcare. So why do we keep trying these failed market-based fixes over and over again? One explanation could simply be the one that, you know, the medical industrial complex is as powerful and as big as they are. And for them, it's no different than Willie Sutton, a bank robber, when he was asked why he robs banks. He said, because that's where the money is. But nurses, certainly physicians, know that profiting from another human's being suffering is immoral and it's unconscionable. This is our current healthcare system. As you can see, it's crazy complex. All of these things add costs. And as we add more arms to this, you know, for different acronyms and new ways to diversify how we provide care, all we're doing is adding cost. Cost containment is key to achieving universal coverage, but trying to use the current system to get to universal health care is not going to work because the system is too expensive as it currently is designed. Seriously, isn't it more politically feasible to get the cost of care down than to add complexity and fragmentation, which just increases cost? That convoluted, dangerous system needs to go, and the one we know we will do the 4 things we want from a healthcare system: cover everyone, save money, improve quality, and most importantly, save lives, must be implemented. And that system is the Minnesota Health Plan here locally in Minnesota, or Medicare for All nationally. We're in a crisis now. We can't keep tinkering. We know what has to be done. We just need to have the political courage to do it. The voters are overwhelmingly with us. This isn't about being politically correct. It's about having the knowledge of how we got here, whether through a Democratic or Republican administration, to solidify our position that the only way to guarantee truly affordable health care for all, no exceptions, is through a single payer healthcare system. As David Lloyd George said, you can't cross a chasm in small steps. I really do hope that this has just helped provide kind of a foundational understanding of how we got to the system we now have, the impact of the false claims of why healthcare costs so much in the United States, and it inspires you to continue your activism in the fight to achieve healthcare justice by either helping us to implement HR 1976, the Medicare for All Act of 2020, or the process here in Minnesota of implementing the Minnesota Health Plan. Healthcare justice is racial justice. Healthcare justice is environmental justice. Healthcare justice is immigrant rights justice. Healthcare justice is gender and LGBTQ justice. Healthcare justice is worker and economic justice. To quote the great labor leader that I always do, Dolores Huerta, si se puede, yes we can. It is our moral obligation to make it so. And don't worry, we're going to make sure you all have access to these slides and my notes. So you didn't have to memorize anything that I just said. You will get a chance to look them over on your own as well when we make them available after the presentation. So I will stop sharing and go on screen and see if I can answer any of the questions that are in the Q&A. Yes, Mark, Dr. Brockie said this today at a board meeting earlier today, patient at risk payment, not value-based payments. I like that a lot. He's exactly right. He also mentioned the insurance companies can and do refuse to take sick people from Medicare Advantage. They can charge extra, but they usually simply refuse to provide a Medicare supplement policy. Again, spot on, Dr. Brockie. What % of money not spent on medical care can the ACO keep as a profit? Yeah, it's what % of the money not spent on medical care? It's interesting because I don't know if it's exactly a %. It's the way it's been explained to me anyways, is that I'm going to make it real simple math just as a, a way to try to explain a complex issue. You've got, let's say, $10,000, Dr. Brockie, you get to take care of me. And I only cost you $7,000, right? The way that I've been told they do it is the 3,000 gets split. You get to keep 1,500, 1,500 goes back to CMS or to DHS or whichever, program is government program is running this particular type of ACO, value-based payment, whatever scheme. If it turns out you've had to spend $15,000 to take care of me instead of the 10, then you are going to actually get this, my understanding, you're going to get less than 10,000 next time and be penalized because you didn't do a good job of trying to coordinate my care and make sure that you caught things on the front end so I didn't cost so much money. This is how it was explained to us when I was serving on Governor Dayton's healthcare financing task force, and I was on the care delivery subgroup. And this is the subject we dove into and tried to really understand better. And that was the simple way it was explained to us. Certainly didn't make any sense to me. And then you also asked, is it fair to say the Center for Innovation has not been allowed to consider a single payer model? I don't think they have at this stage of the game, is my understanding. No, they have not been allowed to actually consider what if we went just straight to a Medicare for all system. And then Dr. Crossan, the insurance companies, big pharma and hospital conglomerates are not going to be happy with what we propose. How do we deal with those objections? Yeah, well, I mean, they got a lot of money, right? We're going to take on the big moneyed interest. There is no question about that. I don't, it's not about them, it's about us. And so it is about talking to people and individuals who really are fed up with the system, who are so tired of the hassles of pre-authorizations and just trying to survive and trying to get healthcare when they need it, not just when they can afford it. And so, yeah, they're going to take us on and they're going to spend a boatload of money. It's going to be our money. It's going to be our healthcare dollars they're going to spend to fight us being able to actually, implement a system that provides healthcare for all. But we're getting pretty close, if we're not there yet, to a tipping point. Where I think the general public is getting sick of this. They're asking for the solutions. They're interested in the solution. They have questions about it, but they're asking different kinds of questions. I very rarely get it's socialized medicine anymore when I go out and talk about this because of all this junk that we just went through. People are so tired of it. They're just more like, so tell me how it will work and what will it cost me and what will it mean for me and my family and what if this happens to me? How do I get that dealt with? Those are the kinds of questions that tell me that there's been a shift. a bit of a narrative shift in how people are thinking about this, and not necessarily being so scared anymore about, oh, it's, a government run program. It's more about, I just need to get health care for me and my family and not go bankrupt in the process. So if there's a better financing system to get us there, what do I care if I'm writing the check to Blue Cross Blue Shield or I'm writing it to the CMS, as long as I can get the care I need when I need it, right? So we can take them on. I'm not that worried about that. They can't make any real good cases about how, I mean, look at this stuff. Can't we throw this in their face and say, you've been telling us you're going to fix this for 50 years. How are you doing? Have the costs gone down? Has anybody's healthcare costs gone down in 50 years? None that I'm aware of. And, the rumor on the street is we're going to get hit hard next year in premium increases, whether you're on the individual market, whether you have an employer provided healthcare, healthcare insurance product, that they're going to come after us again with double-digit increases in premiums. So that's going to just result in a bunch of more cost shifting onto patients. There's going to be a breaking point where people just can't do it anymore. And they're going to rise up and say enough. And that's what we're here for, to make sure that they have a home to say enough, join this movement, and put that pressure on our elected officials so that they start having the political courage to do what they know is the right thing to do. And that's to take care of our population with a public health care financing system. I don't know if there's, how can we get our lawmakers to listen? Well, that's interesting, Dave. I actually did this presentation to a bunch of our lawmakers. I think there were 25 or 30 of them. The Minnesota Health Plan Caucus. I did this about this time last year, actually. The leadership brought me in to do this. And quite frankly, they were kind of like, deers in the headlight. They were like, oh, wow, what, And, at the time they're thinking these are good things, right? That they're doing something that expands the access to care. And a few more people are going to get that care. And that's important. And of course it's important. But it really hasn't done what they were promised to do. And what I said to them is I said, look, I'm giving you a lot of data, a lot of information. Don't expect you to absorb it all right here, right now. Here's what I need you to take away from this. Whether it's MDH or DHS comes in and sits before you and testifies about how some ACO or this program, that program, or value-based payment systems are saving money and they're working and they're improving care, all I want is a red flag to go up for you so that you turn to them and say one simple thing: prove it. Because they can't. And if they can, we're not seeing it anywhere at this stage of the game, because God knows we've been trying to ask them to produce things to prove it, and they haven't shown us anything at this point, not anything that really digs deep into everything that's involved in where this money is going and where it isn't going. So at the end of the day, I think it was really an eye-opener for them and interesting. And as I think most of you know, I'm going to be retiring from M&A at the end of January, and I'm not leaving this movement. That is one thing that is not going to happen. So I am going to take over as the volunteer national coordinator for the labor campaign for single payer. And we're going to try to see if we can't do this kind of a presentation, believe it or not, to the congressional, either the Progressive Caucus or the National Medicare for All Caucus, because it's the same kind of crazy stuff going on up there, right? I mean, we've got Medicare for All bill co-sponsors who sign the annual letter saying, oh, CMS, those Medicare Advantage plans are so fabulous, please keep offering them. I mean, it's just insanity what is going on there. It's destroying Medicare. I don't want Medicare for All if it's going to be a privatized Medicare system. No, thank you. That doesn't get us anywhere. And I know Anna is going to talk a little bit about, obviously, the tremendous day we had on Tuesday here in the state of Minnesota, and how that kind of plays in a little bit to, hopefully, we're not going to get the Minnesota health plan here, enacted in the next 2 years, folks. That's not going to happen. But we do have an opportunity to actually do some true stepping stones and make some changes and potentially even maybe get some hearings in the committees of jurisdiction, if for no other reason than informational reasons, on the Minnesota health plan, so we can start having people testify and get on the record on what is happening within our healthcare system and how it's affecting patients. So I will just check real quick here to see legislators should understand that coverage does not equal access. Yes, Nurse Jean Foreman, you are exactly right about that. And it is hard for them sometimes to understand that, but we're trying. The hard sell of Advantage plans seem to be deeply annoying seniors. Could that be the beginning of stop? I would hope so, Mary. You know, here's where they get us. They've got us over a barrel. It's hard right now. And I think this is part of why congressional leaders actually sign on to that Medicare Advantage letter extolling its virtues. It isn't so much that they believe it's so virtuous, but for seniors that are healthy in particular, they see that it's a cheaper plan, it costs less money, it maybe has a little bit of a tiny dental benefit in it, it might have a few other of those carrots, as we want to call it. And what happens then is they take the plan, and so they're like, hey, this is great, I'm saving money, I'm not paying so much, blah, blah, blah. You better keep those plans going. And they get caught between a rock and a hard spot. It's just like when our legislators here in Minnesota get begged by the insurance companies every session to provide them hundreds of millions of dollars of reinsurance because they've got to shore up their reserves so they can buy down the premium on the individual market, and those double-digit increases don't happen. Our legislators who do not like health insurance at all in the picture vote for that, because if they don't, the people on the exchanges are going to see 15-20% increases in their health insurance premiums, and they've got them caught. Like I said, between a rock and a hard spot. It's insanity. It's insanity. And this is how infiltrated this industry has gotten into the politics of it. But you are right. I mean, at some point, I think, people are getting tired of being bombarded with this, and slowly but surely, more and more senior citizens are figuring out that Medicare Advantage is not truly an advantage. It is more of a disadvantage. But we need to be talking to people, because at the same time, I'm going to go on Medicare now in January. I'll be 65, and I'm going to do traditional Medicare. But I'm lucky, man. I've been working in a union my whole life, and I got a union lifetime health benefit from the union I worked for in California. And so that's going to be my gap plan, and it isn't going to cost me a penny. I don't have to pay anything for that premium out of my pocket. I'm blessed. Most people have to pay, obviously, for their gap insurance, and some of them that can be more of a cost than the Medicare Advantage plan. And for some people, that's a difference of meals and prescription drug costs and things like that. So it matters. So it's hard right now to figure out, how do we tell somebody don't go on that plan when it's the only plan they can afford? So it's really hard. It's not an easy thing, but we've got to just continue to educate on it and try to see if we can convince them that in the long run, paying maybe a little extra for that gap plan now could save you a whole lot of money, because as we get older, we use more healthcare, and we're going to get diagnosed with more things, and those could become pretty catastrophic for out-of-pocket costs. Amy says, afraid of phony courts throwing out single payer. Yeah, I hear you. The only thing we can do with that, I mean, the NHS in England is under attack. The Canadian system is under attack. They're all under attack by privatizers all around the world. This is happening. It's about the people, and the people say, you're not going to do that. You're not going to take away from us our healthcare system. And the best we can do is hope that that becomes the reality. But you're right, it's a danger in the United States in a way that it maybe isn't in some other countries, considering what's going on with particularly our current Supreme Court, right? So it's a legitimate concern. And that's the end of it. So I'm going to turn it over to Ann, because I know she's got some exciting things to talk about. But thanks, everyone. And you know where I am and how to get a hold of me. And feel free to let us know if you've got further questions. But we will provide this for you. And I hope you found it of some value and some interest. Thanks again.
Yeah, thanks so much, Rose. Maybe you could stay on and add anything I
Absolutely.
forget. I think one of our big challenges is to make people, is to help people understand that all of this Medicare Advantage, especially, and then the new direct contracting entities thing that will further privatize Medicare, is draining the Medicare trust fund and will eventually end Medicare as we know it, which is the promise of health care security for seniors and the disabled in this country. And we need to make people outraged, absolutely outraged, at the cost, the administrative cost of our multi-payer system, so that they truly feel it and understand that 34% of the money spent on healthcare in this country goes to the administrative waste of a multi-payer system. It's 1 out of 3 healthcare dollars that is not going to take care of patients. It's going to expensive administrative costs, and including the health insurance industry, the profiteering that is going on the for-profit side of healthcare, and that includes our big health systems as well. Our big hospital and health systems, and also help people understand that physician practices are spending $80,000 to $100,000 per physician just trying to get paid, trying to interact with the insurance companies and get paid. I mean, there's just massive amounts of waste that do not represent actual health care. So we need people outraged on that. We wanted to touch on election 2022, where we're only 2 days past the midterm elections, and we had some pretty exciting results in Minnesota. A lot of us worked really hard to see if we could turn the legislature, hold on to our statewide offices, into a legislature that would be what we call more friendly to health and human services. So even though Healthcare for All Minnesota and Physicians for a National Health Program Minnesota are officially nonpartisan, we know who we are more likely to get to support our healthcare payment reform proposals. And so Minnesota did re-elect Governor Walz, Lieutenant Governor Flanagan on Tuesday, Secretary of State Steve Simon, Attorney General Keith Ellison, who has been a real friend to consumers of healthcare and a real champion of going after the corporations who are ripping people off for the cost of drugs, for example. And then we reelected Julie Blaha as our state auditor, whose job is actually to help towns and cities all over the state manage their costs and get what they need to pay their public servants and pay for public services in outstate Minnesota. So the other thing that happened, which was unbelievable, I guess, to many of us who've been working on this for quite a while, is that the Democratic Farmer Labor Party held the majority in the state house, and we flipped the state Senate to majority DFL by 1 state senator. This opens up the possibility for a whole lot of things that we would like to pursue in the next 2 years. And for context, the what's called the trifecta, where one party holds all the legislative branch and the executive branch and both chambers of the legislative branch. It's called this has occurred only 2 years in the last 31 years. And a lot did get done. I remember that 2013, 2014 biennium. A lot of good policy stuff actually did get done in those 2 years. Maybe people may not remember that we got statewide all-day kindergarten. We raised the minimum wage. They paid back the school shift. So there's a lot of things that are possible when the party that really does care about health and human services is in the majority. So definitely we're going to be looking at strategies for making progress on fixing how we pay for healthcare in Minnesota. And we're going to be asking you to join us in this fight. Any comments, Rose, before I? make
No,
my
not
pitch
not
for?
that I can think. I mean, we're thinking through what those, what those kind of what I would refer to as sort of pathway or stepping stone transitional bills could be. Things like doing direct contracting between the state and providers in our current government, public healthcare programs like Minnesota Care and Medical Assistance, which is our Medicaid program, things of that nature. We really do need to get a financial analysis and study done to compare the Minnesota Health Plan to the current system to try to figure out what would the financing look like, and to demonstrate that it's going to actually save money, because we constantly are told it's not. So let's do the study. If we find out it doesn't, I guess that'd be a big surprise to everybody. But nonetheless, we need to get that done. And then just thinking about, I was honored to serve on Attorney General Ellison's lowering pharmaceutical drug costs task force when he was elected back in 2018. And we did a pretty comprehensive report with some recommendations for how to take on pharma and deal with some life-saving drugs and the cost of them to ensure that people have access to them reasonably and affordably. So I think maybe taking a look at some of those pieces are all part of what we would want to be doing under the Minnesota Health Plan. So maybe we piecemeal it a little bit, get some wins for humans, for for health, and at the same time start building the infrastructure for the Minnesota Health Plan. So I'm kind of excited about the potential of of what we could do here over these next couple of years.
So what I put up on the screen is the whole reason for a nonprofit grassroots organization like ours, Healthcare for All Minnesota, is to create activists and bring in more of us. I guess create more of us, and the activities we do that we ask you to join us in participating in is to educate and engage the public with events like this evening, build our base of support by going out and talking to other people, learn how to have one-on-one conversations on this. I mean, the more you know, the more you're able to field questions on this very highly charged issue. Wish it weren't, but it kind of is. We get out in front of people by going to events, forums, rallies, actions, town hall meetings and stuff, build the skills of volunteers to act and influence change. It isn't just about going to the legislature and asking for what we want. It's really, we have to create more of us who will all go to the legislature, constituents who will demand change of their legislators and are not able to present their ideas knowledgeably. We provide speakers, and we need volunteers and advocates to find opportunities for us to speak, organize actions to promote change, link effectively with other organizations. If you join our quarterly meeting on Thursday, December 8th, you will learn more about our work, the work that we're undertaking to link with other organizations to build a coalition of support for this effort, other nonprofit organizations. Obviously interact effectively with elected representatives on health policy, hold them accountable, create the political will that we need to pass and implement legislation on this issue. And that takes a whole lot of individual conversations with people, one-to-one and group activities. And we thank you again for joining us this evening to learn more about this important issue. This is just a handy guide for keeping track of conversations you might have should you choose to join us in becoming more active. These are some resources. We'll send this out with the slides that we send out to everyone who participates in our event this evening. And I'll point out for the umpteenth time that Senator Marty's book on the case for a common sense universal health system by Senator Marty is kind of the go-to for the why and the how of fixing how we pay for healthcare, at least starting in Minnesota. Our website is hca-mn.org with a lot of information in the resources tab. And then here's some websites of other organizations who are with us around the country. And these websites have a ton of information on them that are useful as well. My favorite is pnhp.org, which is really a lot of information and is kind of the go-to for the economic case for fixing how we pay for healthcare. They're also leading the charge to protect Medicare. So that's a good place to go for actions that you can take to protect Medicare. Then a little bit about, since even though most of us are volunteers, we do have expenses, I'd like Judy Barton to come on and just talk a little bit about, it is that time of year for year-end giving. If you would like to
Sure.
help us out with financial donation support.
Yes. I think most people here in Minnesota know Give to the Max Day. It is actually Minnesota's largest giving quote holiday. It's not an official holiday, but it is in a way. That is next Thursday, November 17th, and it's all day. They have special drawings called golden tickets or special raffles throughout the day, where I believe it's every 15 minutes and then every hour they're doing special raffles. Every donation gets you one entry into that raffle. So it's a great way for us to potentially earn more money. And obviously the more donations we get, the more chances we have at winning those golden tickets. They also have something called power hours, and those are at the 10 a.m. and the 10 p.m. hours. So 10 a.m. to 11 a.m. and 10 p.m. to 11 p.m. And the top 3 Minnesota-based organizations who raise the most money during those hours split $6,000. The top one gets $3,000, second 2, and last 1. So if you're able to coordinate it to be during those hours, that's amazing too. So if you want to give to Healthcare for All Minnesota or to PNHP Minnesota, you can see our Give to the Max web pages down there at the bottom. They have to be through those websites in order, or those web URLs, in order for us to get entries for those special raffles and to be included for the power hours. If you have any questions, don't hesitate to reach out to either myself at Healthcare for All Minnesota or to Jen Crawford at PNHP Minnesota with questions you have regarding it. Thanks, Ann.
Thanks, Judy.
Can
And then
I just add one more thing to that? Sorry, Judy did a great job summing it up, and I just wanted to, as long as we're all together, say what a fun way to give. You know, everybody everybody wants to give as much as they can, and sometimes, you know, in economic times like we have right now, you don't have as much as you'd like. So, you know, what a fun way to make your $10 donation turn into a $510 donation if your donation is the one that gets us that raffle win. So it can be very fun, and we really appreciate everybody's time and attention to it. So thanks so much.
thanks, Jen and Judy both. One of the ways we spread the word is by using social media. We really need a lot more engagement with our social media sites. If you go to YouTube under Healthcare for All Minnesota, you'll see that there are some training sessions on how to use Twitter, Facebook, and Instagram, and YouTube to expand our reach a little bit. We need lots more activity in the form of likes, follows, shares, and posts on these events. Carolyn Hankey is our social media expert, and she's been doing a lot of work on putting up interesting posts, especially on Instagram. Then we do have a calendar. We'd like you to share events like this evening with others in your personal networks. And if you go to hca-mn.org and you see events that you are willing to share with others, there's a registration link embedded in that event. It looks like I had trouble sharing the Facebook event today. I got lots of messages back saying the attachment didn't work, so we'll have to sort that out a little bit. But the calendar links do work. We are going to be tabling at the Minnesota Farmers Union State Convention. We did a bunch of stuff last summer to do outreach. We did the Pride Festival, we did Farm Fest down in Redwood Falls, we did the State Fair. The last, bigger event we've got coming up is the Farmers Union, because we're trying to bring on more people in Greater Minnesota. To one of the biggest expenses for farmers and small business owners in rural Minnesota is the cost of healthcare for their families. So this is a great opportunity for us to interface with them. That's the weekend before Thanksgiving. Saturday, November 19th, I'd like to call your attention to something called an Intergenerational Justice Summit, sponsored by the One Payer States, which is kind of the consortium of states around the country, 17 or so, who are each pursuing a state-based single payer financing system for healthcare. We all want a national health plan eventually, but you know, there are quite a few states around the country who are working on a state-based system that we hope will eventually lead to a national health plan. And that is coming up Saturday, November 19th. One Payer States OPS, or onepayerstates.org, I think is the website. And the purpose of that is to bring a lot of different groups who all have common interests in the greater justice movement. Thursday, December 8th is our quarterly meeting. We're going to try moving it from Saturday to an evening. I'm hoping that's more convenient for people. That's 6:30 p.m. We have invited Senator John Marty, who is the author of the Minnesota Health Plan, to come and talk to us a little bit about what he sees, you know, as the way forward with this pretty big change in the makeup of the state legislature. And then we've invited Dr. Ken Engelhardt to talk about our work specifically on bringing a coalition of organizations together to build a bigger mass movement around the state with especially social justice and other organizations like small business, farmers and people in greater Minnesota, faith-based groups, labor groups, and so on. That whole all the work around that we're doing. Thursday, January 12th, 2023 is going to be the PNHP Minnesota annual meeting. We have two really exciting speakers for that. Dr. Bill Honigman from California, really active in the movement for single payer financing for healthcare. And then Rachel Madley, who is the health policy staffer for Representative Pramila Jayapal, the chief author of the Medicare for All legislation in the U.S. House of Representatives. So maybe put January 12th on your calendar, December 8th on your calendar, and then Friday, December 2nd, our newly formed group called Voices of the Future, which is a young people's organization trying to get the younger generation involved in this work, are going to be sponsoring a screening of the movie The Janes, which is about the movement for women's reproductive rights in the 1970s. That will be at the university campus at 3 o'clock on Friday, December 2nd. So let young people in your life know about this. And we should be posting that on our social media site. And this is my contact information if you ever need to get a hold of me. And then I'll let Jen and Judy do a wrap up for us.
All right, well, thank you so much again, everyone, for joining us tonight. We hope that you enjoyed our presentation. Please look in your email for a follow-up. It will include all of the information we discussed today, our PowerPoint presentations. If you didn't get those dates down for our upcoming events, that's okay. We'll be sending them to you. Also, look for a survey link. We do really appreciate your feedback. It helps us to create content and programming that you appreciate and that you want to see. So help us to create the programming that works for you. And we thank you so much. And we look forward to seeing you in December on the second Thursday for our wrap-up meeting for 2022. Thanks so much, guys. Have a great night.
I see that Judy put a link for the Intergenerational Justice Summit sponsored by One Payer States in the chat. So before we close this out, if anybody wants to click on that link, you can open it up in your browser and use it to check out that event. I think it's just a couple hours on that Saturday, November 19th. So thank you again. Thanks so much to Rose, our speaker for tonight, and Judy and Jen, our moderators. And thank you all for attending.